Welcome everybody to the Random Anesthesia Topic podcast. In this episode we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Gianluca Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started.
By the way, do you like my background today? This is my dad's evil overlord office.
I was wondering if you just brought the books in to look smart today.
No, this is my dad. So these are all like books on economics and more importantly, microeconomics and like price theory and like, oh yeah.
Those are probably serving him really well right now because no one fucking knows what's going to happen economically.
Well, my dad does.
He doesn't. I bet he didn't predict the fucking market today.
No, he didn't, but he's finding the tariffs on the Antarctic pretty hilarious.
That's our topic for tonight. So anesthesia, urban legends, and dogmas. Okay. So, how...
I feel like sitting in the evil chair overlord office is actually perfect for this
topic.
Exactly.
Yeah. So do you check your potassium in every single greyhound you anesthetize?
Wow, we just went right into that. There was whatsoever. Well, I can see where this is going.
Okay, so there are some reports.
This is a double-edged sword. This is a double-edged sword, so I think Bailey should answer first.
Yeah, I would love to answer because I have some thoughts. I mean, I will say I pretty aggressively check labs in my patients because the one thing that will kill your patient faster than you can blink is potassium. And it hasn't happened to me, but I know it is a thing. I know it's not just greyhounds. There's the literature that came out from Jordan Nickel and Hoffmeister that showed that was a retrospective study showing patients died of high potassium. So I think it's a thing that we need to just be mindful of because it's a killer. It's a killer.
It is.
What was that other paper though that also came out talking about like specifically like the sight hounds and like what they believe to be like an idiopathic hyperkalemia?
Yes. So that's another
There was one in press, and I never actually saw if it went to like final approval in press, but that could be the same paper.
No, it's a different one. That one I think is Mama.
Yeah, maybe that was the one where they I feel like who else was on it?
And I thought that I don't know if that was
there was a thing. There was no clear like pathophysiology, although they deliberated whether or not it was associated with like the alpha 2s, and I was like, oh fuck, here we go with rumors.
So that alpha 2 stuff is based on the paper from Sadihi in Big Cat.
Yeah.
But I will say I also know someone who is collecting blood from greyhounds to look for hyperkalemia in some sort of, I don't know. But if anyone who's listening to this has a greyhound who's being anesthetized, I think Minnesota is doing some work on them and collecting blood samples. So reach out to University of Minnesota. Caitlin Tierney is the one on it.
The paper that I'm thinking of was Kershid, Nancy Brock, Dr. Kudo, the internist, and Stacy Jones.
Okay.
Yeah, and that was a case report.
So
all this to say, I think there's people who are trying to figure out if there's something there, and more power to them. I don't know that I will check it, religiously. Like if they've had a normal potassium prior, I will usually accept it. But if labs are over 3 to 6 months old and this is an older patient, especially if they have any evidence of kidney disease, I'm 100% checking something with electrolytes that morning because it's just you're playing with fire.
Yeah, and it is, right? But on the other side, right?
Mm-hmm.
There is a couple of papers that did show that if you have hyperkalemia, you don't necessarily have ECG changes, right?
Except I would argue that once you add inhalant, that's like adding gasoline to the fire. Like the inhalant anesthetics can definitely precipitate those arrhythmias where maybe they wouldn't have been present if the patient was awake. And like, so you either say, I'm going to play injectable on all these cases to avoid the arrhythmia, or you throw ISO in there and potentially precipitate an arrhythmia that wasn't present without inhalant
I
ISO.
think quoting Tasha.
No, don't drag me into this shit. I was very happy listening.
Quoting Tasha.
Oof.
Isoflurane sends everything to shit, right?
Isoflurane is the root of all evil, and the higher you turn it, the more it goes to shit. Yeah.
Anyway, so yeah, okay, fair. Although those papers were in anesthetized patients, so
Okay. All right. I'll
but
take it. But I do know there's some of us who believe there is a link between inhalant hyperkalemia and precipitating arrhythmias.
no, and I can believe that, right? Like, it's fair.
Yeah.
That's
I
fair.
also think it's like, in the grand, to my mind, in the grand scheme of things, like for where I work, for where most of us work, you're talking about what's probably under $100 of lab work on a patient who is probably spending,
No,
that's
that's fair.
1 to 5% of the total invoice. So I have a hard time sitting there and having to justify this when we're talking about a much higher bill, and I'm just trying to prevent the patient from crashing and burning within the first 30 seconds of anesthesia.
And also, like 99.8% of my patients, anyway, I'm going to have a repeat blood work from the day of the procedure, which includes electrolytes. And the
No, of
reason is
course.
because my patient population is made up of crazy ASA5Es
Oh yeah.
that are circling the drain. And I'm basically running blood work every 20 to 30 minutes. Like, I don't do, healthy cat and neuter space stuff. So, most of my patients are going to get their electrolytes and radiometer read as the baseline before I even rock up. So my answer is yes, I've checked it, but you have to remember I'm skewed based on my population bias.
Totally agree.
Yeah.
Totally agree.
No, of course. And like, the reference I'm making is, if you have a patient that had blood work, the potassium is normal. Like, I don't necessarily recheck it at induction necessarily, but, if the blood work has been fairly recent, like less than a month old or whatnot, which is usually what we get,
Yeah.
and the potassium was normal before, like, I'm not necessarily going to recheck it at induction, even if it's a greyhound. And then, if there is any CG changes, sure, I'll keep an eye on it. But like,
Yeah, I would generally agree with that. Like if it's within a fair amount of time, a month or under, I'm probably going to leave it alone. But like 3 to 6 months is where I
yeah,
start to
yeah,
get
that's
a
different story.
little bit more cagey. And then I would say this there's so many times that we get send off blood work where we have hyperkalemia because of spurious results, because the blood sat on the clot and the potassium went up, blah blah blah.
Or you pull through the catheter, which I hate, but
Yeah,
everyone
so
likes to
then
do it. And
the potassium is 5.5 on the send off lab work a week ago, and it's like, not going forward until I see day of labs. Like, we have to confirm that this is a lab result. I mean, I understand it probably is, but gosh, that's like playing with fire to my mind.
Okay. Now, second dogma. Um,
I hope it's about cats this time. It'll be catma.
okay. Okay. Well, that was that.
honestly, let's just end the podcast there because not another joke is going to
Yeah,
be better than that
yeah,
one.
exactly. See you next time,
Just
guys.
wait till we get
Night,
the horse
guys. That
smoke.
was awesome.
So, okay, you have. Do you avoid certain opioids in cats due to the risk of hyperthermia post-op?
No,
No,
no. I,
no.
I thought you were going somewhere, and I was like, "Ooh, that's a really good question." And then you're like hyperthermia, and I was like, "Bah."
Honestly, I could feel Bailey's internal sphincters clenching from here, but no, I don't avoid it. And I don't worry that much about opioid induced hypothermia. I mean, it's self limiting, it resolves, and you can have it. I've seen it with buprenorphine, I've
Yep,
seen it
for
with
sure.
oxy, I've seen it with methadone, I've seen it with hydro. And,
Mhm.
there's only a certain number that are technically like researched or reported, but that's just because nobody can be bothered to do the study.
Mhm.
And, it tends to also have a ceiling limit on it, so it doesn't become pathologically hypothermic.
Yeah.
So these things don't sweat it. Now, where it can be complicated, I find, is where it's confounded with other things like, what if the cat also had phlebitis? What if we also think it might be going septic? Then we start having to thinking outside the box, where we start plucking out each issue to determine the nature of the hyperthermia versus is it true pyrexia. So that's my only comment. But for the most part, I don't avoid anything except surgeons.
God. So, all right. So then that makes me want to ask, like, because your question was
Okay.
going somewhere that didn't go, I want to know, do you ever consider the uh
The increase in sympathetic tone.
the increase in sympathetic tone associated with certain opioids? Do you ever think about that as part of your opioid choice?
So actually, I have been.
Oh,
Haven't been sleeping at night thinking about,
all right.
thinking about the fucking sympathetic. No, but I actually did give a lecture in a Fetch Charlotte about maintaining anesthetic stability, right, and how different drugs have max sparing effects and whatnot, right. So even buprenorphine has zero max sparing effect in cats.
Mm-hmm. Mm-hmm.
It's crazy, right? Like
Use
morphine.
at 11, buprenorphine has zero max sparing effect in dogs too. What a bullshit peri-anesthetic drug that is.
I mean, okay. In dogs, actually, it does have some sparing effect, right? Like,
Right.
but in cats, it has like zero, right? Like, so 30%, I think it's in dogs, but zero in cats. Morphine as well, 30% in dogs, zero in cats.
Oh, you are singing the song of Bailey's people right now.
Yeah, no, it's crazy, right? Like
I can hear like Bruno and Pasco just like in my ear, like talking about all the cat studies of like, we did fentanyl and half the cats who had, MAC reduction, when we did the crossover, then they didn't have MAC reduction and this and that. And like,
yeah, like I said, you're singing the song of Bailey's people. Right?
crazy.
Look at him. He's like a wash and joy and comfort. Fucking creepy.
So, okay, fair. So yeah, I've been thinking about that, right? Like, choosing the right, how to improve my anesthetic stability during surgery, and maybe not resorting too much to like, a fentanyl CRI or something like that versus something more like Dexmed or
I'm
something.
really glad that this podcast is all actually improving our anesthesia. Like the three of us are starting to do better.
It's normal, right? Like, we share ideas and we learn. Like, you can know everything, right? Like, that's the deal, right? There's no way on earth
oh yeah.
that you can know everything, right? So we all studied or been trained, in different places, and we all have different inputs. And actually, I think that this is something that probably collectively as a college we should be doing more often, right? Like, just meet and chat and like come up with ideas and see how other people are doing stuff. The single meeting a year, I think it's nearly enough.
Which is a 99.8% of the time about the exam. And not actually about anything helpful to the rest of us.
Right.
No,
Also,
but
like,
also, I mean, you've having sleepless nights about feline sympathetic tone. How do you think we felt about the lidocaine bomb? I mean, for like 2 weeks, we couldn't recover.
So I was like, do I even use lidocaine now, or is it like?
Yeah, and like one of my VTS technicians who I've worked with for like yonks, she was like, I listened to the lidocaine episode, and she was like, I couldn't sleep either. She's like, I mean, you trained me, and then like you were thrown for the loop, so I was thrown for the loop, and I was like, oh yeah, the lidocaine thing. I'm still upset. Like,
anyway, so other common myth. Um, how about how much relevance do you give to breeds or patients that potentially have like MDR1 mutation or ABC cassette kind of mutation, whatever they're calling it now? Do you like, are you really like, oh, I shouldn't use Torb, I shouldn't use ispromazine, I shouldn't use this and that? Or how real do you think that is, right? Like do you actually see, first off, it's hard to find a patient, I think, that actually has been tested for it. But if you did, like, how worried are you about that stuff?
Well, as the former blog person on the website, I can reference the MDR1 Mutations, A Big Deal or Not by Elizabeth Gowdy De Angelis. And she gives a very comprehensive overview on MDR1 mutations and how they may or may not affect anesthetic drugs. And overall, my takeaway was it's a bit of a nothing burger, but it could be a something burger, but it's mostly a nothing burger. So
Exactly.
I don't.
It's one of those things where it's probably not going to happen. When it does, it sucks hard.
Yep, for sure. And like I can't remember, there's a university, I think it's Washington maybe, or maybe it's Oregon, who like is the leader in a lot of it's Washington State who does a lot of who does some of the research on like the MDR1 and which drugs are impacted in dogs and this and
Are we
that.
still calling it MDR1? I thought we were supposed to be calling it like ACBC or what have you.
Well, I
Yeah,
mean,
yeah, something like that.
when it was written years ago, like in 2023 when it was published, it was
That was 2 years
listed
ago.
as an MDR1, but they do mention the ABCB1 gene.
Yeah, something like that.
2 years
Yeah.
can be a long time when you've recently survived a global pandemic.
Right. True story. Yeah.
Cool. And then lastly, so, this is something that came up on Facebook, probably 1 week or two ago. And in one of the Facebook groups, somebody was debating.
Exactly why I don't follow Facebook
Why
veterinary
don't we
anesthesia
say
No, but
groups.
so?
it's interesting. It's interesting, right? Like, so sometimes there is really good questions, right? Sometimes it's, a lot of people don't have access to, unfortunately, one of us, right? So, like, I get it that it's kind of hard to get, accurate, quote unquote, information out there sometimes, right? And we don't really do a good job at it, right? Sometimes, in anesthesia, we have a huge lack of, support for people, right? There's very few groups that actually do something, right? They were debating maximum PIP pressure, so like peak inspiratory pressures, right? That you're giving to your patient when you breathe, right? So there is this common thing about like, hey, don't go above 20 centimeters of water.
Hmm.
What do you think about that? Do you think it's real? Do you think it's, do you do anything different? Because there was a huge debate on, 15 versus 20 versus 25 versus 18, does it even matter?
This is what I think. So I think that when you take a turnpike curve on or off a highway and they give you a speed limit, they cut that speed limit down probably by like 50% below the actual number that your car is going to two wheel it, and you may or may not tip over. And I think that's also true of the 10, 20 centimeters of water, because let me tell you, particularly in dogs, I will drive above that pressure if I need to keep you alive.
Totally agree. I was like trying to come up with a topic, and like ventilation was like immediately where my brain went to when I was thinking about like what's my topic going to be. So like preview for
Is
those.
that because you blew up the bag in a barrel?
No, no. It is.
Bring out the bird.
I have a lot of
So
have a lot of thoughts on ventilation.
for
I would
people,
say
for people
So
that,
you have
that
a
look,
lot of thoughts on everything from hot dogs to cracker pizza to ventilation to sympathetic tone. Like, we're used to
on
this by
a
now. Oh,
give a
yeah.
prop.
OMG. So for whoever is listening, Ryan is showing us this beautiful hood.
So I wanted to follow up from last week's episode or our special episode whenever it's out. So if you,
Listen, if we're ever looking for sponsors, we should reach out to some sausage companies
oh my
because
god, I would be so excited.
I mean,
Anyway, the hot dog that Dr. Pockel was referencing is called Pilsa, and they're found all over Iceland. They're made with lamb, beef, and pork. They're boiled. They're served on a steam bun with ketchup, Icelandic mustard, a mayo-based remoulade, raw chopped onions, and fried onion bits. And that sounds fucking good as hell. I just want to.
Side note, have either of you two been to Iceland?
I
Yeah.
have not, but I was like,
Okay,
this
I've
book
been
talks
like
about
4
all the hot dogs.
Take Icelandic food just a little bit with caution because there's a lot of stuff there that's been marinated in various forms of urine. And I just like, I don't know what the hell Icelandic mustard involves, but immediately my red
Probably
flag
urine.
I was like, betcha there's urine, betcha there's urine. So yeah, I mean,
Wait, wait,
yeah,
wait, wait.
they ferment all sorts of stuff is like put in fermented urine. It's like a holdover from Viking times where they were basically starving
Human
to death.
urine?
No, horse and cow for the most part.
I didn't read anything about urine when I did review this, but maybe I need to look a little closer. But it sounds
It might not be the hot dog itself, but it could be because when they stipulated Icelandic mustard, and I'm thinking to myself, what does that mean? And then my first thought was maybe it has urine in it. So, or like, like breast of puffin. So yeah, I just, I'm sure, I mean, I don't want to insult Icelandic people. It's a super cool country. I've been there 4 times. Love it.
Did you have a hot dog though?
I don't think I did. I think I stayed like close to like a lot of the seafoody type things
Mm.
that were urine free. But there is a whole urine based food culture there. Just heads up,
Hmm.
heads up. But yeah, no, I'm glad you looked up the Icelandic wieners.
Yeah, this
Uh,
book just
like
came
I
in,
said,
so I had to read through it.
thank you to all our followers I've been building with the successive podcasters because we're getting up to the level now where sausage sponsorship of our veterinary anesthesia podcast is a potential.
Fingers crossed. So anyway, peak inspiratory pressures.
Right, I forgot what we were talking about.
That's
And
what
I
my
don't know how we
ventilator
went
makes.
from peak inspiratory pressure to urine,
Yep.
but
We're all over the place. I like to get such a high peak inspiratory pressure that it actually evacuates the bladder. I just get so much pressure across that diaphragm, it translates straight into the bladder. But no, actually, I've had a couple really good topical cases because general rule of thumb, I fall, man, I really want to like bring up my topic, but I want to spoil it and like
no,
worse.
no, don't spoil it.
I
no,
know,
don't spoil your topic.
I know, but I like have so many feelings about ventilation and like it's just gonna spill over. But like, yeah, I'm definitely in the 10 to 20 peak inspiratory pressure range on the average case. Like average dog and cat who I'm ventilating, 10 to 20 for sure. That's what I'm sticking to. Now, the other day, we had a case, probably a patient with like a pulmonary thromboembolism, had clots everywhere. First time I'm almost 100% sure I saw a myocardial infarct on the ECG and like ST elevation. I was like,
Nice.
I like put the
Very
ECG on. I was like, damn, this dog has ST elevation. I was like so jazzed. I like took pictures of it. I sent it to a bunch of people, and
So
like,
this was actually my lead on my other question, right? So like whatever, we're gonna get to ST elevation or depression.
so anyway,
But
that dog would not saturate. Like nothing was going, and I was like, we are gonna whip these lungs into shape. And I was like, crack up that ventilator. We're going to get the alveolar recruitment maneuvers. You
yeah,
get that like ventilation up to like 35 centimeters of water pressure. Get the PEEP valve. We're going to get the ventilator out. We're going to like hammer these lungs and we're going to inflate the shit out of them. And we're going to get any alveoli that want to play in to participate because we have to saturate this dog because 80 for this lung is not acceptable.
so you
You know what? I
ventilated
do
it.
not want Bailey to ever ventilate me, but I would say
That's
too.
why I do anesthesia ventilation, not fucking critical care who's like, the lungs will
Let's go to
slowly.
6 centimeters of water, but set the RR at 2,000 and then wonder why our PaCO2 is 114. Yeah,
Oh
no,
my god, it's like we're going to 6 centimeters of water. Everyone batten down the hatches.
no, I think if you have, especially if you have restrictive intrapulmonary disease, so the actual pulmonary interstitium is highly diseased,
Oh yeah.
don't drive pressures above 20. It will be dead in 3 minutes.
Oh yeah.
So I
Ooh.
also think the difference between 15 and 20 or 22, those are arbitrary. I think that is a waste of an argument. That's really not where we need to be focusing our attention. But these abject numbers, like, you put a patient, for example, like the cutoff for Bain is 10 kilos or 5 kilos or 7 kilos. Holy shit. Understand how it works. And then there is no weight based. I know you hate the Bain, but there is no weight cutoff. And it's the same thing with the ventilator. Like understand exactly what the different types of intrathoracic pressures are. Like, what's the difference between intrapulmonary and transpulmonary? And also, like, what's going on in terms of lung pathology and ventilation and oxygenation? And what will be your repercussions if you do something either super aggressive or way too passive? Like, I hate these absolute rules about things because it just means we've stopped thinking about what's going on in terms of physiology.
Are you going to ask about re-expansion pulmonary edema?
Yeah, I mean, so of course, but in reality,
Of course,
Is that
yes.
like were you getting like a vibe about that? Because I was just like,
well, I was
I
thinking
didn't get
about
that.
that, right? So when you go so high, right? You had PEEP, right? For sure, you did.
In yeah, like if I would say like in the case where I have to reach for these high peak inspiratory pressures, like to me, I'm adding PEEP because it probably means this patient is hypoxemic, and one of the ways we're dealing with that is with PEEP.
Yeah. Okay. So you know, did you see any potential like re-expansion injury, any pulmonary edema afterwards, or?
Knock wood. I have not seen re-expansion pulmonary edema. I will relay a story. In my residency, I was called in for a diaphragmatic hernia repair. And I walked in, and it was a bulldog being manually ventilated with like a modified non-rebreathing circuit. I think it was technically like a Mapleson F, if anyone wants to get fancy, or maybe a Mapleson B. I know. Fucking Maplesons, right?
That's a super weird choice for that entire situation. But anyway, whatever.
With no pressure gauge. I was like, well,
Were you doing anesthesia like in a field with no
no,
electricity? Like, what's happening
no,
here?
no.
No,
I
no,
was walking
no,
in. I
Natasha.
was
He
walking
was a
in.
he was a Davis.
I know. I was walking in to go assess my patient before I started anesthesia, and it was a bulldog who was in respiratory distress and was intubated and on positive pressure ventilation, but they didn't get out like the whole vent because it was going to surgery, so they were just manually ventilating with this modified Mapleson system. And like I was like, well, if any case is going to get re-expansion pulmonary edema, it's definitely this one where we have no clue what the peak inspiratory pressure was.
Like, why in this particular situation would you pull a Jackson Reese? Like, you'd be like, oh, this is going badly. Oh, it has a hernia. Oh, I'm worried about this. I'm going to handbag with a gaugeless Jackson Reese.
Fucking handbagging. Like, if you're really like, I'm gonna handbag this case, like, you should rethink your career. I have never had success. Like,
I will switch to a couple, like, manual assisted
yes,
breaths.
the manual assisted
I
breath,
like
not like
to feel compliance.
I'm gonna ventilate a case. Ooh, I have another good compliance. I've got a lot of good stories in the last couple weeks. I saw an actual airway obstruction in
Please, yeah, stop calling it handbagging, by the way. That's
CSF
disgusting.
tech, like a live patient in a dog. I've never actually seen the airway obstruct, and I was like, "Hey guys, I think the airway is obstructing." And I was like, "Let me bag." Oh, it's tight as hell. Oh, his chest ain't moving. Whenever you can stop, maybe give it a break. Dog can't breathe. Everything was fine. Um,
Yeah, the next time I have a respiratory crisis under anesthesia, I'm definitely going to think, you know what? Someone
It's
pass me
probably,
a Jackson Reese so I can just
yeah.
oh,
maybe.
Somebody hand me a Jackson Reese too.
yeah,
On. Like, are you doing trauma anesthesia in a war zone? Like, I don't understand. I don't
I
understand.
hate those. Like the bane is the bane of my existence.
The
We
bane of
know.
your existence.
I
We
know.
know,
Um,
Bailey.
I could. I
Is
have
it
like
worse
a
than ketchup on a hot dog or like same?
Same,
so
same. I have like a half-written blog on how much I hate non-rebreathers, and I just like I have so many feelings. It's like halfway written, and I've put out so much vitriol on like why non-rebreathers are like terrible pieces of shit, and like I just am like, does anyone want to read this? Does anyone want to read my like diatribe on No.
100% Bailey. I would read it and laugh. And also then think about this whole Jackson Reese situation and just maintain the state. This is, again, I'm going to be up tonight just in a state of bewilderment, trying to think my way through the
About the
physics,
fucking
what
Jackson.
was happening in this situation, and to come to no real resolution. And then, I don't know. So I just, but I would read your vitriolic blog on anti non-rebreathing circuits.
I hate them.
So how about the whole story of like you can't put a patient less than 5 kgs or 7 kgs or 10 kgs, right? Because this is another dogma that's being perpetrated, for ages now in veterinary anesthesia, right? You can put something's more than 5 kgs on a rebreather, right?
Do you
What
remember
do
a couple of podcasts ago when I said you have to understand the machine and its components? Otherwise, you don't actually understand anesthesia. This is the perfect example. You can put whatever you want on a fracking non-rebreathing as long as you have a flow meter and sufficient oxygen to do so. It has nothing to do with the circuit. And I'm just like, if you understand the machine, then you can answer that question without any input from the three of us. So
No, I get it, but like our listeners may not understand the machine, right? So
but do
that's
they
why they're
understand
listening.
rage?
Listeners may not have as many feelings about a bane and a rebreather as we do, but I like
Yes.
so I think that is a holdover from like anesthesia from like a long time ago because back in the day the one-way unidirectional valves were made, they were metal discs. They were almost like the weight of a silver dollar. Like for anyone who, remembers a silver dollar. I
Also,
know.
also, why do you know what the weight of the former disc was?
Well,
Like
because we had, I mean,
unidirectional valves or something? Like,
because once again in my residency we had some older machines that had they still had the metal discs in them and like
of
yeah.
course. That's why I was driving the bag in the barrel. Yeah.
But that's why those smaller patients probably cannot move those more weighted discs. But now they're like such lightweight plastic. Like I
Yeah.
will say, I push the limit every day when I get a small patient. I'm like, can I fucking get this thing on the goddamn rebreather? Because I'm gonna fucking try for sure, 100%. And like the text will be like, but Dr. Bailey, it's a small little dog, and I was like, and I don't give a shit. Get me the circle. And then
Nice.
like, and if I'm wrong, I will 100% switch this dog to the ventilator.
Is it just me or is Bailey extra funny tonight?
Oh my god. It's because you got me on like some topics that I really am like deeply passionate about and I like care way more than anyone ever should. But yeah, I'll put it on and then if they rebreathe, I'll be like, all right, well, I guess we have to think about the bane while I get the ventilator going because it's like we have ventilation. We could just put this patient on the ventilator
Yeah,
and then it takes out the whole question of whether the patient can breathe on the circuit or not.
exactly.
And
Exactly.
like my equipment, and I've got like not really good equipment for the anesthesia machine, I can go down to like 1 kilo. I think I took a dog that was half a kilo on a circle,
Yeah.
and it was
I mean,
just fine.
if you're ventilating them and the ventilator can handle such a small tidal volume, it
But
doesn't
remember, a
take.
lot of GPs won't have a
Yes.
ventilator.
Oh, for sure.
Or they
For
will
sure.
go back and forth. And so I always make sure they understand what the indication is or like what's the level of tolerance. For example, like if you're going to rebreathe like 2 points of CO2, I really
Yep.
don't give 2 points of shit. But
Exactly.
if it's really like causing depth challenge and making you hypercapnic and blah blah blah, then sure. So I do think I don't have this passionate hatred of Bane that you do, but I do like people to understand that if you really are struggling with a patient and resistance to breathing because of the additional components of the circle, I
Hmm.
also think you're right, Bailey. It is a hangover probably from the days where people were doing like the to and fro, like you got to basically like breathe back and forth over the bubbling boil vaporizer, like, fuck. But I still, I still think non-rebreathing does also have a place too. Don't forget an ambu bag is a Mapleson C, and we all use an ambu
That
bag.
is your like. That's a
Some little
classic
mustache face.
Bartell.
And also too, they use non-rebreathing all the time. So for example, if you had a tension pneumothorax and you were doing like flow by non-rebreathing as opposed to like BiPAP or CPAP, because those will kill somebody who has a perforated lung. So put that in your little hot dog pipe and smoke it.
I personally think that non-rebreathers are far more challenging from like the anesthetist perspective. The vaporizer changes are so rapid that like it is just so easy to be over under with
Oh
just
yeah,
little hair movements on
absolutely.
the vaporizer. And I find like if I'm running a patient on a non-rebreather, I am often playing vaporizer jockey and I'm just like constantly touching that thing when I've got a lot of other things that I really would be better doing. Like, I mean, there's a phone, it's not going to text itself, you know, I have emails to read, there's social media that I could be reviewing.
Crushing candies. Like,
I can't be touching this vaporizer all the time.
so sometimes I just gently adjust the surgery table without telling the surgeons, just make them think that they're going insane, like that kind of stuff.
That's why I hate you. That's why I fucking hate you.
They don't hate me, they fear me, and there's a difference.
But so okay, fair. Okay, so yeah, so we can put patients that are smaller, long story short, on a rebreather as long as either we have a ventilator or you have a not Stonehenge era anesthesia machine.
And you have to have capnography, though. I guess that's also another. I mean, for us, that's a given because we all work in specialty. But like, yeah, you probably also really need capnography if you're going to try to take small patients and put them on a rebreather.
Oh, that's so cute.
Cutest cat in the
Oh,
world, Brownie.
Loves it.
little brownie. So okay, fair. So I think we're uncovering a lot of like this little kind of dogmas, right, along the line. So how about Dexmed in diabetic patients?
Ooh.
Boom. Do you use it? You don't. What would you do? Because I mean, to be fair, I think it depends on which kind of diabetes the patient have.
Hmm.
Oh, I like
Say
that
more.
qualification. I also think this is a really complicated question, and I might crush some candies while Bailey takes care. Just kidding. But listen, this is my general attitude. I like alpha 2 agonists. I think they play a very important role in the majority of the cases with which I am involved. I love wheat thins, but here's the thing. If you have a true diabetes mellitus animal, you have to remember there's a difference between blood sugar and intracellular sugar, right? So that's really the important parameter. And the thing is that dexmedetomidine for the most part affects the blood sugar level, but not necessarily the intracellular. However, if I can do something to avoid having to manage a complicated interpretation or in any way contribute to deregulation of that diabetic patient, then I'm going to err on the side of caution and that capacity. But if my diabetic patient needs dexmedetomidine, like there's a strong and appropriate indication otherwise, then that's fine. I'm going to do it.
Yeah, I would echo similar sentiments. I would say I have not routinely used it in diabetic patients. I can't think of a diabetic patient in which I have used it. Like I think, I also think there's merit in using it in cases that it's warranted. So for whatever reason, we've got a diabetic dog who wants to tear your face off and is intractable, right? You know, should we be should we be dicking around with like, you know, ACE and opioid sedation that may not get the level of sedation to make that patient handleable? Probably not. Like when we can hit it with Dexmed, get it handleable in a safe, quick fashion. I think that's like a good.
Well, listen, my own spicy little brown cat Brownie, who has diabetes mellitus, You know, sometimes you just need the Dexmed to sedate that one because she's a real serial killer when she's in the clinic. And for the safety of both my staff and her, I'm going to give it to her. And anyway, half the time she's freaking insulin resistant from pancreatitis anyway. So what difference does it make?
Right. That's what I'm saying. Like, if you have a cat, right? It's, some of them are insulin resistant. So then at that point, doesn't even matter, right?
Exactly.
Especially if you have a cat with HCM, right? Where you want to give the Dexmed.
To manage that feline sympathetic tone associated with HCM.
Exactly.
Exactly.
That's a perfect example. Dexmed manages sympathetic tone great, for the record. Like, it stabilizes that tone nice and smooth.
I agree. But like I said, Beanie, there are very few things where you're going to find where I have absolute objections to thinking through complicated situations and maybe coming up with things that are a little more creative than the bog standard person might be used to for their, day-to-day anesthesia. And that's fine, but that's really what we're meant to do. And that's not necessarily what everybody is meant to do. So I'm cool with it.
Yeah, that's and that's part of that's part of our job, right? That's what we do.
Our job is to take things that nobody else wants to anesthetize and do it successfully, safely, and wake those patients up and send them home. Like, that's the whole point of what we do. And there's about a bajillion different ways to do it, and to do it well. And there's a lot of things that I do and I don't do. And we would never have consensus agreement on so many different things. And I think that's really where the experience and the art come in. And that's why it's nice to talk to other anesthesiologists. Because, like, when you guys did the fireside chat with Manuel, and he was saying, I have friends who do ketamine and HCM cats all the time. And far and away, those cats do absolutely fine. And so, yeah. Well, to be fair, we all could use the qualification most of the time. I mean, I've crashed patients twice in my career on famotidine, so heads up on that one.
Oh, yeah.
Nice.
Yeah. So, at the end of the day, if you do anything enough, the statistics of the situation will always catch up with you, even if you're best practice, textbook, like all that kind of stuff, because there's something idiosyncratic that will be beyond your knowledge and your control. And, it will burn you, every once in a while, just to give you a little dose of humility and put you back in the box. And that's just the way the cookie crumbles. So,
yeah. No, absolutely right. So, and then I think this is going to be the last question for tonight. So, some practices do 10 ml per kip per hours of fluids during surgery.
I hate
practices
so much.
So here's what I've been doing, right? In preparation for this session, I've been looking at Facebook posts. And listserv stuff, right? And I was
outsourcing his work here, Bartel, is what we're learning. I said, so you're outsourcing your work is what Bartel and I are learning, where we're using all our brains to come up with these insane topics we talk about.
Those are questions that people ask.
No, I'm only kidding.
I'm trying to give people the answers to the questions that they normally ask.
For sure.
Right? And then we'll talk about ventilation next time, Ryan. Don't worry.
Yeah, then we'll talk about my insane ventilation theories.
We'll get there.
It could be cocktail night again if we do that. So sorry, I totally interjected.
The question was, right, like, do you think there is any value in having a different fluid rate, right? Like, so 5 ml per kip per hour versus 10 versus 3.
Oh, I'm all over the place. My fluid rates are like, how am I feeling today? How wet is it out there?
It doesn't matter.
Just in case anyone can't see, I'm holding my head in my hands right now because I'm just remiss about this topic.
I feel like we were this may just show my complete lack of understanding of anesthesia as a student. Probably. I mean, I feel like I was probably a pretty strong anesthesia student. I kind of knew I wanted to do it. I'm sure my faculty will probably beg to differ, but I feel like back in the day when I was a student, everything was like 10 mils per kilo, fucking hosing
absolutely.
you down. And it was just like,
10 was the low end, 20 was the high end. So if
oh, I
you
never saw it. That sounds
well,
crazy.
I'm much, much older than the two of you. So, I mean, like for sure, like, 20 would be the high if you were hypovolemic or actively bleeding and da, 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 da. This is what happened in the early 2000s, everybody. Okay.
I didn't know you were that old.
Well, that's because I Botox.
Aw. Okay, whatever.
Look how smooth this forehead is, everybody. Look at the smooth. Does it move? Oh,
Soon enough, people are going to be like, Dr. Bailey, you use 10 mils per kilo per hour of fluids? I'll be like, yeah. And my hairline tells the story.
All
Yeah, I
right.
thought everything was 10 TPLO, 10 mils per kilo. CT, 10 mils per kilo. I I really think a lot about fluid rates, and I go back and forth all the time. And like,
Do you really fucking do?
oh, everything gets its own. I'm like, long MRI, 3 mils per kilo per hour, no open body cavity. We're gonna be under anesthesia for like 2+ hours. Like, yeah, three. Or
I
like,
mean,
I don't know. Sometimes they do like a CT, and I'll do like 10 mils per kilo per hour because it's a quick CT, and I'm thinking about it as like the total amount of fluid based on a very good
okay, okay. Yeah,
from
that's a good
Dr.
way.
Lydia Love. Want to
Yeah,
shout that one out on
I agree. I'm going to shout out Lydia Love for that too, because it's really
Wing
more about
Symposium.
the total
she's
volume
amazing.
you're delivering over time in
Yes,
most instances, as opposed to the difference between the rate between 5 and 10. And
Absolutely.
obviously, if your rate is billion mils per hour, then rate will then become a factor that you need to take into consideration. But it's really like, if you set them at 3 mils per kg per hour and the neuter takes 7 minutes, like congrats, you gave them zero point 0.4 mils. Like, why bother with fluid
exactly.
at all?
Yep.
So it's the total volume and over
Yeah.
time, and it's the type of volume as well, because, after 30 minutes, like most of that shenanigan is long gone from the vascular space. So yeah, this is why fluids just fill me with consternation. Like
You do get that is like your passion, and I'm just like, put them on the fluids. Who cares?
when
But
I presented the 10-year literature review of fluid therapy last year at AVA, and I
wow,
started the conversation with is, before anyone gets excited, I don't have any answers for you.
no, that is
And
the
I just
consensus.
went through, like,
No one
tell you
fucking
how many papers on fluid therapy you
Nobody knows.
yeah.
Nobody knows. I think it's a
nobody knows,
matter.
nobody has the right answer. It's one of those things that this is this is serious, like, quackery, is my opinion. Fluid therapy
Totally,
is fucking quackery.
totally.
Yes.
Did any of you guys see the any of you all, sorry, see the JAVMA fluid therapy prior to surgery for GI foreign body reduced the amount of fluids given intra-op, I think was the
I mean, it makes sense, right? These
yeah.
are patients that normally don't eat slash puke,
Yeah, and
right?
they were saying that there was like much less interventions if the patients were like like essentially rehydrated prior to anesthesia. I'm
Yeah,
pretty sure it was JAVMA with
Well,
the
I love it when people publish incredibly obvious things, but yeah, no shit. Like the
yeah,
better
but in clinical practice, that's not done. They're like, "Oh, the dog's got a foreign body. Get him in the OR as fast as we possibly can." It's
Yeah, but
like,
that's why anesthesia is supposed to be the stopgap, because I'll be like, this patient's not optimized. You have not solved fluid resuscitation and electrolyte balance appropriately. And I'm like, have a nice day. Although secretly, I actually just take it and fix it myself because it's
yeah,
faster and better. But
exactly. Yeah,
yeah,
that's exactly what
I mean, it totally makes
happened.
sense. Like, you basically, this paper is a clinical example of, if you optimize the patient before anesthesia, it does
Mhm.
better under anesthesia. So you just published an obvious statement.
no shit. No
But
shit.
now you have something. But now we, the like, people who believe in it, have something we can be like, here's the evidence. Here's evidence. You
Everything.
can read it. You can read this paper by someone who's not me, who wrote this, and they said this, and it was clear, and blah 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 blah. Like there was the paper from the UK that's like you can sit on a GDV for a couple hours, and they do just fine as long as you stabilize them and optimize them prior to anesthesia. Pretty sure that was a UK paper, if I remember correct. Don't remember the author, so sorry.
Fail.
Look at you not referencing your stuff,
I
Ryan.
know, I know. I'm
Happens
yeah,
with age.
I know, my brain.
It
Sometimes I just can't
happens with
remember the
age.
authors.
The longer
Um,
you live, the more your head starts to fill with stuff, which means that you start to forget more because you have a larger capacity of things to remember.
That's
I
true.
listened to that podcast on memory. So, but
Uh,
yeah, no, I think like fluids is quackery for the most part. And I
totally.
agree. Like, obviously, like the more you stabilize the patient, the less work we're going to do under anesthesia. But in most instances, I don't win that battle, and I'm not interested in spending 3 hours of my life waiting for someone else to clue into it. So I usually just fix it myself.
Yeah, exactly. Like I end up just doing it. And like, sometimes you have those patients who are coming in and they do need emergent surgery and they are somewhat dehydrated. You do what you can. And then, in that first hour, maybe I am running them on the old school 10 mils per kilo, but it's a 1 hour limit. And I set the pump and I set it all up. So it's all like, me proof. And so like at 1 hour, the fluid pump beeps, it clicks over to the maintenance rate. We go down to 5 mils per kilo per hour. I reevaluate. I think, I talk to a surgeon. Hey, surgeon, are the guts all dry? And he's like, yeah, they're so dry. And I'm like, all right, well, we're going to keep going at, 10 mils per kilo per hour. Or like, yeah, I constantly adjust my fluid rates. Like this is not a
Also, the hour
static.
cutoff is entirely arbitrary. Like, why
Yeah,
is it not
totally made that.
2 minutes or
Yeah.
why is it not 7? Like, there's so
Yeah,
much of this.
sure.
Like, you know how you have like this meltdown over like the bane. The sentence that tips me over the fucking edge is careful with fluids. That's the most meaningless sentence in the history of medicine. I have no idea what that sentence means, and I hate when people say it or write it in a report. And I was like, that, like, I will stroke out over be judicious with
All
fluids.
right. All right.
That,
So
that sentence just sends me into a rage.
very, very, very last question. And then you let everybody go. What do you think of the dogma? It has heart disease. We can't give fluids,
Love
or
it. I
we
love
need to
it.
lower the fluid rate to
I
3
get
ml per kg per hour
so
to a month.
excited. I am like
It's usually on the echo report.
I can't answer this question because I have to go to the happy place in my head.
I get so excited when I have the dog, and Bartel's probably gonna have a fucking stroke here. So Bartel, make sure you're seated. Get ready.
The aneurysm is already forming just from the question.
We have the dog's under anesthesia. Blood pressure's dropped. We're hypotensive, and I'm like, give a fluid bolus. And the technician looks at me like, but Dr. Bailey, this dog has murmur. And I'm like, give fluid bolus. And like, are you sure? Do we really? Do we only want to give 5? And I'm like, give it no.
Is every day at work for you like an episode of The Muppet Show?
It sounds a lot like it. Yes.
Guys,
No, listen,
I'm
I'm
more
a
like,
believer if you need volume, whatever you want to qualify that as. If a crystalloid is a colloid, if it's, you need platelets, if you need plasma, whatever. If you need it, you need it.
yep.
If your heart is diseased, I can work around that to a certain point. But at the end of the day, if I do cause a little bit of congestion, I can usually back you back out of that anyway. So I don't sweat it and I have no hard objection to it. But this statement, heart disease, is almost as meaningless as be careful with fluid therapy. What does heart disease mean?
Yeah.
Electrical? Is it pericardial?
Right.
Is it myocardial? Is it mild? Is it moderate? Is it severe? Is it compensated? Like, is it multifactorial? Fuck off. Like, I don't know what, and that question just makes me so mad.
And there's all the evidence suggests that you should not be running these patients dry, especially like coming from the human literature where they have like fucking real heart disease. We have like play pretend heart disease, like, oh, the heart's kind of bad or whatever. But they have like real fucking heart disease because they smoke and they drink and their hearts are all jacked up and like they live a lot longer. So their hearts are in all kinds of different failure that we can even possibly comprehend. And like all the evidence says, do not run these patients dry. There is no benefit to doing that. Don't do it. Like, we should not be doing that. We should not be falling into the trap of doing that. It's stupid. And it's like, I mean, I don't like.
You need to make sure you splice this segment and then share it to all the cardiologists because I fucking live for that moment. Let me tell you.
I mean, if I was to go into boards and I was like, well, the cardiology report says be careful with fluids. So I'll be running this patient dry, Dr. Pippendop. And he would be like, he would just walk out of the room, slam his pencil on the table. Oh my god, slam his pencil on the table, and I would fail right there on the spot. Like that's like you would have like I would have to say I would maximize end diastolic volume to like ensure that the patient is well volume loaded prior to anesthesia, not run them dry. Blah blah blah. And like, yeah, you want to make sure your patient is adequately volume loaded.
Absolutely.
A more full ventricle does beat stronger. We don't need to
Yes.
overfill it, but we want the Goldilocks. Like, should we be doing preoperative echo? Like, should we learn
You could.
pre-op echo? Should we learn AFAST and like TFAST and all that?
Yeah,
Probably.
you
But we've
could.
got
That's why
enough
the
on our
anesthesiologist in human medicine does all the TEE, right? Like,
that
Yep.
was like a whole conversation at AVA in London was that like like the big thing for cardiothoracic human anesthesiologists was like learning TEE. And now there's like a big movement of like cardio trying to take back TEE and perform the TEE under like anesthesia now instead of having the
well, you know
anesthesia.
what? I'm not going to advocate for that because if they're going to give me anesthesia recommendations, then I'm going to TEE my own fracking patients. How do you like that, cardio? How do you like that?
Um, Jokes aside, though, like, and that's what I tell my students all the time. If the heart doesn't have enough blood, it's not going to pump. Like,
No,
what
it's
does
not
it
a guys. It's not a dry pump.
I think there's a
It's not pneumatic. It's not. It's not. You need to
There's a
have volume.
specific reflex, I think, not herring brewer. I don't think it's bezel gerish. What's the like empty heart causes arrhythmias and like the you know what I'm talking about? Like the empty ventricle, the squeezing of the empty ventricle
There is
causes like
there
one of
is
the cardiac reflexes.
suicide right ventricle, you mean, like, or
Not that
something?
one.
No,
That's part
suicide
of it.
right ventricle is when the right ventricle just stops fucking contracting, whether there's volume or not.
An empty heart beating, like a empty heart contracting causes it's a cardiac reflex. I don't remember what it is, but
Yeah.
it's a cardiac reflex. Fuck that I was thinking about a fucking cardio thing and now I remember. I saw the best cardio thing. They said that you should be careful with fluids and that when the patient is standing, you should administer a dose of Lasix.
It's the Betzold-Jarisch reflex.
I
So
thought it was Bezel Jerish. God
Of
damn it.
course, it was the bezel
I should
gel.
have said Bezel Jerish. God damn it.
yeah, an empty ventricle causes a reflex bradycardia because the heart's like, well, if I don't need to pump, I might as
Yes.
well die.
That is exactly what it's doing. It's like, fuck.
Fuck.
Yeah, so this cardiologist was like, when the patient is standing, you should administer Lasix. And I was like,
Okay.
hell yeah. What?
Specifically when it's standing.
Yes.
If it doesn't stand, you don't.
I, you know, I did call them for the recommendations because I was like, this is a waste of my time and I'm not going to do that. In fact, the other day I called someone for an echo report. I was like, can I have the echo report? And they said, oh, well, we're not done finalizing it, but I can read you the anesthesia things. And I like damn near cut them off mid sentence. I was like, no, 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 no. I'll decide how to anesthetize this patient. Thank you so much.
And that's exactly why I'll be doing all my own transesophageal echocardiology. The
I
rest of
just need the numbers you calculated, please, to decide how this patient's heart is. Thank you.
unbelievable. Unbelievable. That's so irritating to me.
And on that note, I think on that note, we can end this night here.
We
Thank
should
you
end
very
it
much.
before it ends in violence. Like,
Yeah, I see the rage in Ryan's face, and I was like, "Holy
I
shit!"
gotta go get my pitchfork and go down to the nearest cardiologist.
if you get your pitchfork, I'll get my lighted torch, and we'll go like on our way over to like ACVIM bracket cardio bracket.
I was like, he's either gonna kill somebody or rob an hot dog stand. That was-
Ooh, don't threaten me with a good time.
so, thank you everyone for listening. Remember, you can watch us on Apple Podcasts or YouTube. We'll see you next time.
Thanks,
Thanks,
everyone.
everybody.